Hello, ladies and gentlemen. Welcome to Triple N Media. I am Dr. Nik Nikam, a cardiologist from Houston, Texas. This is cardiology seminars, and on our YouTube channel, we have more than 300 lectures related to cardiology, basic science, and advanced topics such as valvular heart disease, along with all the ACC/AHA guidelines from 2014 all the way up to 2022. So I encourage you to watch those. Hopefully that will help you to prepare for dealing with your patients and also for examinations for internal medicine or cardiology boards. I have created a cardiology rotation manual. I have created a cardiology rotation manual which contains 250 pages of chock-full use. I have created a cardiology rotation manual which has 250 pages of pertinent information related to cardiology practice. It's good for medical students, nurses, residents, fellows, and even for practicing internists. So you can get a free copy of this one, and I'll tell you at the end of the presentation how you can get a copy of this one. So let's proceed with the presentation. The main feature presentation is the cardiology board exam EKG interpretation, junctional and ventricular arrhythmias. So let us see what we can learn from here. And if you are taking cardiology boards, you need to get familiarized with this answer key sheet, which follows a systematic pattern. I have already done a separate video on the overall view of this EKG interpretation. Please do watch that. And I also created a separate video for general features, P-wave abnormalities, and there is a separate video for atrial rhythm problems. Today we're going to be focusing on AV junctional and ventricular arrhythmias. So let us continue with the presentation. So the focus is going to be AV junctional rhythms and ventricular rhythms. So when you are sitting in the exam hall, all you are interested in learning is these aspects and not all the fancy case reports that you hear that are few and far apart. First of all, in the junctional department, you need to know AV junctional premature complexes, how they look, how they differ from ventricular complexes, how they differ from atrial premature complexes. Then we need to be able to identify AV junctional escape complexes and escape rhythm. And then we have AV junctional tachycardia. In the ventricular segment, we look at the ventricular premature complexes and particularly the terminology. What is the difference between bigeminy? What is the difference between bigeminy and trigeminy? And what is the difference between trigeminy and triplet? What is a short burst of VTach? What is a sustained VTach? We're going to look into all those things. Then there's a unique feature which we may see from time to time known as the ventricular parasystole, and I'm going to show you an example of that and try to explain as why we see ventricular parasystole. Of course, we need to be able to recognize ventricular tachycardia. Then we need to know accelerated idioventricular rhythm. Where do we come across idioventricular rhythm? How does the accelerated idioventricular rhythm look? And how does it differentiate from accelerated junctional rhythm? See, finally, ventricular fibrillation. In order to understand the origin of these arrhythmias, we need to revisit the electrical system of the heart. And here we have the sinus node, then we have the interatrial branches which connect the sinus node to the AV node. Then we have the bundle of His and the right bundle and the left bundle branches. And here's the Bachmann bundle which supplies the left atrium. Today we are focusing on the AV junctional and ventricular arrhythmias. That means we are talking about AV node and also possibly His bundle. So we are not concerned about the connections from the sinus node to the AV node, nor are we concerned about the bundle branches like the right or the left bundle branches. Mainly it is connected to the AV node and sometimes His bundle, but we don't need to worry about His bundle because there's no mention of His bundle. on the EKG key. So we're going to be focusing on AV junctional rhythm, and the ventricular rhythms can be accounted for the PVCs or the couplets or triplets or trigemini arising either from the right or the left ventricle. But they're not going to ask you to differentiate between which ventricle it is arising from, but looking at the QRS orientation in the chest leads, we can say whether this is arising from the right side or whether it is arising from the left side. If it's arising from the left side, the right side leads will be positive. If it's arising from the right side, the left chest leads will be positive. That's a simple tip there. That's just an additional bonus point. Anyway, let us look at some examples here. Here we have a sinus beat, sinus beat, sinus beat, sinus beat, pause, and this is looks like a supraventricular beat. What is this? Is this a PAC? We don't see any P wave here, so it's not PAC. Is it AV junctional? Perhaps, yes. It could be junctional rhythm. Could it be His bundle? We can't say by surface electrocardiogram. But what caused this pause? That's the next question. I mean, this is beyond the scope of this particular examination, but just for understanding purpose, I'm going to telling you here, because this could be a precursor of what might transpire in the coming days or hours. Because if you look at the PR segments here and the ST segments and T wave changes, this T wave looks different from these T waves. What does that mean? Is there a blocked PAC causing a pause, and then we have a escape junctional rhythm? Why am I concerned about blocked PAC? I mean, having dealt with thousands of cardiac surgery patients, when I see PACs, I get more concerned, because the next thing you're going to get called for is a patient with the atrial fibrillation with rapid ventricular response. And as I have seen it time and again, PACs are not something that we want to totally ignore. That's just some extra clinical point, but I'm just giving you in the context in which we need to be looking at the whole picture. So that is an escape junctional beat following a pause. And here is a rhythm which is slower, 1, 2, 3, 4, 5, 6. It's about 50. So the QRS looks a little bit wider, but it looks like there is an acute injury pattern. If this is lead 2, then we are looking at possibly inferior myocardial infarction with acute ischemic T wave changes and there are no P waves. So is this an accelerated junctional rhythm? That's the question. And that's how we come to a conclusion. Could it be escape accelerated ventricular rhythm? It could be, because the QRS interval is it's not quite wide enough to call accelerated idioventricular rhythm, but this is an accelerated junctional rhythm, which is frequently seen in the presence of an inferior myocardial infarction. And here we have a sinus, 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 sinus. There's some distortion here, and it looks like supraventricular, similar to the previous ones. I don't see a definite P wave here. And whenever you don't see a P wave, look at the T wave and the ST segment and see any deformity. I don't really see. So this could be a junctional premature beat. And here's a much better example of a premature junctional beat. Here's another one: sinus, 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 and a premature beat with maybe a retrograde P wave here. So this is an example of junctional premature beats. And here we have a rhythm which is let's look at the rate here. It's 1, 2, 3, that's 100, 150, about 125 to 130. So the rate is 125 beats per minute. So this is tachycardia. Then when the rate is 125, we have to think about paroxysmal atrial tachycardia with 2-to-1 conduction, or sinus tachycardia, or atrial tachycardia, or junctional tachycardia. If this is atrial tachycardia, you would expect the PR interval to be normal, close to normal, but here you have a very short PR interval, which makes us suspect this is junctional tachycardia. Is this flutter? No, we don't see any flutter waves. Is this multifocal atrial tachycardia? We don't see multiple P wave morphologies. It's not atrial fibrillation. The rate is pretty regular. Is this paroxysmal atrial tachycardia with 2 to 1 block? I don't think so, because we don't see any other deflections to represent a second P wave. So this is a junctional tachycardia. Let's look at the next one. And here we have an example of a normal beat, wide QRS complex, normal beat, wide QRS complex, normal beat, wide QRS complex, normal beat, wide QRS complex. So we have frequent PVCs. When every other beat is a PVC, it is known as ventricular bigeminy. Please pay attention to these words, ventricular bigeminy, and we're going to look at all the terminologies of different ventricular beats, and so that you don't get confused in the exam hall when you're in a rush. So this is ventricular bigeminy, and let's look at here. Now we have a normal beat, and a PVC. Normal beat, PVC. This is ventricular trigeminy. In the previous, here we saw normal beat PVC, whereas here, if you see 2 normal beats and a PVC, that's ventricular trigeminy, whereas this is like a ventricular triplet. So see the difference between trigeminy and ventricular triplets. 3 beats happening in a row is called ventricular triplets. And here we have ventricular bigeminy. Then we have ventricular couplets and ventricular triplets, and a normal sinus beat. Boy, it's a pretty sick heart. And here, if you have more than 3 beats, it's known as short burst of V-tach. If you have 3 beats, it is ventricular triplet. So we can see a combination of these. You can have multifocal PVCs in a heart failure patient. And here we have what looks like a tachycardia with the radius almost like a little less than 150, maybe 135, 140. So this is tachycardia. When we are talking about 140 tachycardia, we need to think about atrial rate. Atrial rate could be 280, which falls in the category of atrial flutter. Is this flutter with 2 to 1 conduction? I don't see any flutter waves, but the QRS complex is pretty wide, and it has what looks like a right bundle branch block pattern. And given the fact that the QRS is wide, and it is a tachycardia, the first thing that would come to my mind is this ventricular tachycardia? How can we substantiate if this is ventricular tachycardia? One of the hallmarks of ventricular tachycardia is if you see a fusion beat where an occasional atrial complex gets through the AV node and creates a fusion beat. And if you see that, then it is almost diagnostic of ventricular tachycardia, especially in a patient with an underlying bundle branch block. But here we don't see any evidence of fusion beats, but sometimes we may be able to identify independent atrial activity in the STT segments, but I don't see that. But anyway, I'm going to quote this as ventricular tachycardia. I'm going to give you an extra bonus point. Do you know where this ectopic focus is coming from? As you know, ventricular tachycardia is an ectopic focus. It is not, it sometimes can be micro re-entry within an ischemic or a scar region. But for most purposes, it is an ectopic focus. Well, it is arising from the left side of the heart because the right side of the leads are showing positive deflection. So it could be somewhere in the left ventricle. And this is left anterior hemiblock. That means the impulse is going upwards. So it could be coming from the lower part of the ventricle going upwards. Anyway, that's too much. Let's move on. And here we have an example of a normal beat, a PVC, and a normal beat. Generally, when we have a PVC, the refractory period is reset. As a result, it is usually followed by a compensatory pause. Same thing happens with the atrial premature beats, but the compensatory pause is much shorter with atrial premature beats compared to ventricular premature beats. However, occasionally we have a premature ventricular beat which fails to reset the refractory period of the sinus node. As a result, the next beat just comes on time. That's all we need to know as far as this is concerned. If you see PVCs with no intervening pause, think about ventricular parasystole. And what do we got here? Here we have a wide QRS rhythm. The rate is approximately 55. Now the question is this accelerated idioventricular rhythm or is this ventricular escape rhythm? Escape rhythm, the rates are usually less than 40 beats per minute. Since this is wide QRS complex, then we need to think about accelerated idioventricular rhythm. Accelerated idioventricular rhythm because the QRS is pretty wide and the rate is approximately 55, so that falls in the range of 40 to 60, which is accelerated idioventricular rhythm. Could it be accelerated junctional rhythm? If this is accelerated junctional rhythm, you would have expected the QRS to be narrow unless the patient had an underlying bundle branch block. So I would just quote this as accelerated idioventricular rhythm. And here is an example of a real sick heart. We don't see much atrial activity whatsoever, and the QRS complexes are just like less than 40 beats per minute, and this falls under the category of escape ventricular rhythm. Ventricular escape complexes or rhythm. So that's an example of ventricular escape rhythm. And here's an example of ventricular fibrillation. And as you can see, we see coarse fibrillatory waves in all the leads. The main thing we need to be concerned about is sometimes we can see very fine fibrillation, which may be very hard to differentiate from, for example, atrial fibrillation. However, you're not going to see our QRS complexes, and this is ventricular fibrillation. And we need to be able to differentiate ventricular fibrillation with torsade, where the axis keeps shifting from time to time. Torsade is covered in another segment of this EKG key, but I just wanted to show this side by side so you can see the difference. And when you see these coarse fibrillatory waves, think about ventricular fibrillation. So ladies and gentlemen, this is a quick review of junctional rhythms and ventricular arrhythmias that we need to know as far as cardiology boards are concerned. And you can get a free copy of this cardiology rotation manual by sending me an email at Dr. that is drnikam at gmail.com. The address is in the comments section. The email is in the comment section, and just send me an email and I'll get you a copy of this book. Thank you so much for watching this presentation, and please do subscribe to our YouTube channel. I will see you in the next presentation.